All right, who wants to start?
I can start.
All right.
All right. I'm gonna move this to a different screen so it looks bigger because someone showed it to me on the webinar and my screen always looked really small. Anyways, this is a guy who came in with, this time it was a known diagnosis, so it wasn't that hard, but still a nice MRI imaging findings where you have this very characteristic infiltrative mass throughout the epicardial fat. Insinuating, the couple of cases I've seen, it really does predominantly insinuate around the atria. And even though it insinuates around the atria and it doesn't have a ton of mass effect, even the SVC coming through it winds up being not significantly narrowed. And let me just show some. So here, just some spin echo sequences. Not the best. The guy was sleeping. So this is a T1 weighted sequence. And with lymphoma, you would expect some, usually low signal or hypointense to muscle. And here it's, iso maybe slightly hyperintense. Similarly, the T2s are slightly hyperintense to muscle. And if you look at the T1 post, this thing is avidly enhancing. For the sake of time, I won't show the perfusion, but the perfusion shows that this avidly enhances. A little bit of an atypical enhancement pattern also for lymphoma. So, and then the real impressive thing is the MDEs, where you can see this just pronounced enhancement through this. And I think we've all shown a couple of cases here and there. The one case I showed where it was a de novo diagnosis was he had pleural thickening and enhancement. This guy doesn't have any of that. And this is a case of Erdheim-Chester. And I'll show you the CTs as well. So here's and we have PET, and I'll spare you the PETs. The PETs show that. And here's the clear renal involvement. And no pleural, no pleural involvement, no septal thickening, but here we can see that really classic enhancing mass centered in the kind of epicardial fat, invaginating and really not even narrowing the coronary arteries. So just another nice.
I'll step in for David and ask, where's the bone sclerosis? David just jumped on. David, I was trying to take your place with Erdheim-Chester and ask for the bone findings.
I didn't see any here. Isn't it usually extremity, the bone findings, or is it?
It's typically symmetrical long bones, femurs and tibias and fibulas.
Yeah.
Symmetrical.
Yeah, it's outside the chest, but so maybe I'll have to look at an MSK film and see if they're there. But I forgot about that part. And what was this case? I don't remember. Oh, this is interesting. So here's a kid who, for whatever reason, they're not really sure, developed diffuse alveolar damage. And this is the initial scan. I hear, maybe it's DAD, maybe there's some of it's just fluid. But anyways, his course, he went on to develop pretty fulminant acute lung injury, kind of with a DAD pattern. What's really impressive, so this is, let's just say, day X, and this is 2 weeks later. And I know we've all seen cystic destruction and various parenchymal abnormalities from acute lung injury. I've never seen someone develop emphysema this is a young kid. He's like 22, never smoked. And I've never seen someone develop emphysema. I don't know if it's cicatricial. I don't know what the cause is, but nonetheless, pretty extensive.
Seth, it's interesting. It's in the non-dependent aerated lung. You wonder if it's like a barotrauma.
Yeah, but he never developed a pneumothorax. He never. I don't know.
Or something, or oxygen radicals that cause tissue destruction. I don't know. David, have you seen this, or Howard, or anyone else?
I've seen it develop from infection, but I don't think just alveolar damage. But if it's emphysema, I've seen from infection, but this could be cysts.
Well, to me, there's, the structures of the secondary lobules going through them. I mean, if you look at it all, to me, these look more like blown out lobules than cystic structures. To me, I mean, it's like the normal component of the lung. I showed this.
Was intubated, right? He was on pressure.
He was intubated. He was on pressure.
Right.
And the question is there some small airway injury? Because in most, it's either destruction of the alveolar wall itself, or with Hogg's paper showing that emphysema usually starts with injury to the small airway. Answer is I don't know, but I've just never. And I actually showed this to the guys at Maryland, to Galvin, all these people, and they'd never seen that before. So it would be interesting
as well.
Yeah, and it is in the less involved spared lungs. So is it a barotrauma? Is it some sort of, again, we've all seen barotrauma in various forms. He never had PIE. He never had other findings, but I'll follow up if we ever if he survives and if we get another CT.
Oh, he's got a bit in his anterior right middle lobe, but it's still asymmetric.
Yeah, no, he has it. No, he has it in the right. He has it down here.
Yeah.
So it's in the more spared lung, but it's all over the place.
Peculiar, yeah.
And this is, I don't remember what this case is. Oh, so here's a guy who kind of went down the tubes on. So clearly a smoker. And here he is now coming in with upper lobe predominance, ground glass nodules, and some lower lobe. And actually, this is after. They treated him. So let's see right here. I think this is it. Let's see here. So here we go. So I thought this was going, he's a smoker, or at least I thought he was a smoker. Looks like he's a smoker. And has these findings, which I thought would be, the worst case of RB DIP I've seen, at least the RB portion. But it turns out, because we know that if he was a non-smoker, I'd just say, oh, it's HP. It's a pretty classic look for HP. But we know that the injury to the lung is at the same unit of the respiratory bronchiole, and you get similar appearing injury, although the ground glass nodules, I have to admit, do appear to be more pronounced in HP. So anyways, he quit smoking, turns out 5 years before, and got a parakeet, or a cockatiel. And he tested positive for skin antigens and all that stuff. So this is a guy who kind of fooled me, because again, thinking he's an active smoker, which he wasn't, and this was HP in a guy who quit smoking.
Wow. So our pulmonologists, our ILD people say that the whole smoking, only non-smokers get HP thing, they say that's a bunch of nonsense too. I mean, I don't know, but that's, because I had said that one time, like you're saying, asking, and they're like, oh, it's irrelevant. I don't know what everyone else thinks, but.
I mean, most of the literature says, most of the literature says it's protected to some degree. Talking to Lynch at National Jewish, they say they've seen the occasional case, but they say it's extraordinarily uncommon. There are a lot of papers looking at lymphocyte populations in smokers versus non-smokers, and the immune modulation of nicotine and the decreased antigen deposition because of the bronchial wall thickening. I mean, there's a lot of stuff to support it, but I don't know. I mean, it's
also been my experience that patients who smoke with HP are more likely to have fibrosis. Whether they're predisposed or they're just coexisting injuries. But and I don't know. I mean, I don't know of a good study that divvied them up, but that seems to be when I do see it in people with a tobacco history, usually fibrotic. I haven't seen a lot of cases of like the active, like you're showing here, Seth.
Yeah. But yeah, no, they did everything, and he's positive. It's funny. So I'd never really looked at these bird panels before, but these bird panels go into quite an amount of depth about the actual bird. and there's like 6 or 7, or if not more, birds on the bird panel, and he specifically tested positive for the bird that he owns. Anyways, this is a person with these peribronchiolar consolidated masses, nodularity, unilateral, looks, well, there's a couple down there, but really right side greater than left. It wasn't growing, so this patient has this over many years. It wasn't growing. People were still thinking it would be malignancy because what would these things be? So there's 2 interesting things about this case. One, the patient underwent a lung biopsy, which is understandable, and we can see that it's never good to have that much air in your left atrium after a biopsy. And this patient had a massive air embolism, and here's the MRI. Now, I don't know, this is all fancy stuff to me, but surprisingly, the MR itself didn't look too bad, but these are these cerebral blood flow and whatever things they do. Clearly, this was right after she was better, and the biopsy of this came back as IgG4. So this was a case of parenchymal IgG4 disease. And again, we have studies going back a couple of years showing it's unchanged, and then also a patient who had a bad air embolism with basically cerebral infarcts, or at least hypoperfusion, that recovered. So anyways, I don't know if any of you guys would look at this and say, oh, that's clearly IgG4 disease. I mean, they showed it in Path Conference, and I'm like, yeah, okay, that's fine. It fits the bill, but that's just one of these diagnoses that I still don't make a good presumptive diagnosis on prospectively.
Right.
I thought you were going to tell us it was a weird sarcoid.
Yeah, no, I thought it,
like sort of as mass-like sarcoid does, because some of it looked a little like conglomerate nodules, a little.
It does. No, it absolutely does. And I raised that. I said, gave a couple things, amyloid, some other weird things, and it was IgG4.
Interesting. Yep.
Yeah, with the I haven't seen too many big air embolisms like that. Here we go. Now we have a layering in the left atrium.
Oh, geez.
And left ventricle. But all right, those are my cases.
All right. And, who's next?
I've got a couple.
All right.
Are we all viewing the same CT scan?
Yes, we are.
Okay, so this person is, I think, a chemotherapy patient, had some immune compromise, people viewed all of these small nodules here, and the thought was that this was metastasis, but a whole lot of these nodules are really in an airways distribution, and then there's a cavitary lesion here in the base, cavitary lesion over here. So I was suspicious that this could be infection based on the number of lesions associated with airways here, and I thought maybe this is Mycobacterium avium. Turns out the person is a marijuana smoker, and in bronchoscopy they recovered aspergillus. So I think this is another case of aspergillus bronchiolitis and bronchitis from smoking
David,
marijuana.
some of that looks like LCH in the upper zones. Any chance that was a component?
Yeah, I was going to say the same thing, because the tips of the lingual and the right middle lobe are completely normal too.
And some of them have little cavitations in them, and there were some cysts.
Well, they didn't recover LCH. I don't know where they looked, and
yeah, they wouldn't get that on a bronch probably.
But I think the reason that there's appears to be cavities for some of these lesions is that they're really air bronchograms. It's this is stuff in the bronchial walls, and I think you're maybe seeing the lumen. So things like this, is that what makes you think of like some
the bubbly looking nodules? Some are solid, some look like Cheerios, and as you went down, there were fewer and fewer of them, and then you got to the big ugly things at the bases.
Right.
And it has been described in marijuana smokers, I believe. That looks more.
Well-
That stuff looks more infectious down there. I agree, but
Yeah. Okay, he may have more than one thing.
you didn't have any earlier imaging showing that these had just popped up.
No, I didn't have a lot of earlier imaging on this. I don't even have any chest radiographs. I feel really deprived.
Yeah, I would wonder about admixed LCH in there, to be honest.
Okay, so here's our next case, and this is this case was just presented this week in a medicine conference. This woman is in her late 50s. She is of Indian descent, and she was visiting people in India and noted facial swelling, and it didn't feel good. And so she ended up coming back and got worked up. But this is an earlier radiograph on her to show a pretty normal mediastinum. And then if we advance to current era here, let's see, I hope I can bring it up here. Here's a more current radiograph at the time that she was ill, and you can see that the mediastinum has widened, and she has some left hilar enlargement here and probably extra tissue here below the left main bronchus. So this is looking like lymphadenopathy. Now her symptoms were swelling of her head and neck. So she had this swelling, and then she had a cranial nerve problem. She had a left Bell's palsy, and then she developed a right Bell's palsy, and then she had some difficulty swallowing. So there was some CT imaging of her neck initially because she had so much swelling there, and she's got this massive enlargement here of salivary glands on both sides. Somebody had to tell me that that's what those were. And there was a cystic component to this. So bilateral salivary gland enlargement. You can see how this is changing the contours of her neck here, just below her head. And then she had chest CT, chest, abdomen, pelvis, and she's got a ton of lymphadenopathy, as was hinted at, but I think really underestimated by that change in her chest radiographs. So lots of lymphadenopathy here, and not anything very striking in her lungs. It's pretty low lung volume here, and maybe there's a little bit of edema here, but I wouldn't say much about parenchymal findings here. So there was an ultimate, let me just show you the coronals here for the salivary gland enlargement. This is pretty impressive to me. So diagnosis, class?
Sarcoid?
Sarcoid with uveo
Silentinitis.
uveo-parotid fever, also known as Hereford syndrome, evidently. So I still need to look this up, but this was sarcoid, which was involving her salivary glands as well as her mediastinal lymph nodes. I thought, as this case was being presented as an unknown, there was going to be lymphoma with some sort of a paraneoplastic syndrome. And evidently the bilateral Bell's palsy suggests autoimmune disease. So that's probably part of the sarcoid, immune dysregulation or something like that. It's probably associated with her inflammatory condition rather than, a unilateral Bell's palsy, I think is a herpes virus thing. But if it's bilateral, then you start to think about autoimmune. So that fits with her. So she had it on one side and then developed it on the other. Okay, so this was a case of sarcoid presenting as uveo-parotid fever. I think I got the right name there. So I don't think I have any previous cases of this uveo stuff. Okay, now here's a radiograph on a fellow who could not lie flat for a CT scan, and he's got this upper mediastinal convexity on both sides, and then he's got these apical lesions here which are bulging down, depressing his lungs from both sides. And this was also there again in 2019, but you see the contour of these apical lesions a little bit better. And this is what CT looks like on this fellow, who you'll see why he can't lie flat, because not only does he have all of this mediastinal tissue, but he's got this huge soft tissue mass here with some central low attenuation stuff sticking off of his back. Here's a more sagittal view. He couldn't lie on his back because of this large lesion back here. And let's go back to coronal here. And you can see that, well, this is coronal abdomen, so I'll include some better pictures. So this is all neurofibromatosis, and he's got plexiform neurofibromas involving his over the lung apices. Let's pull this back. Over the lung apices up here, and then along the mediastinum and on down. So a ton of neurofibromas everywhere. And there was a biopsy of that lesion sticking off of his back, and I think that was also a neurofibroma. Subsequent imaging showed a less of a cystic component to it, so they might have drained something out of it. So it seemed more solid later on. It was fairly uniform on PET scanning, it being pretty warm, but I'll check the pathology to see whether it was something more malignant than just another neurofibroma. Okay, so pretty dramatic neurofibromatosis. There were some skin lesions too on some of these cross sections. You could see something jutting off the skin at another point, for instance, back here.
And David, he has some nice dural ectasia down low in his spine. I think as you're showing vaginals, it kind of popped out nicely.
Yeah, and this guy, one of the reasons he's got big neurofibromas in his spinal canal too, and there's a lot of compression of his cord, and some of those were visible on some of the imaging. But
yeah, they're encasing his mesenteric vessels too.
Yeah. So I would grant them the diagnosis. I mean, here's a very nice enlargement of the intervertebral foramina. Okay, neurofibromatosis.
Did he have any lung findings like cysts or anything?
You know, I don't think he did.
I've only seen it a few times. I'm just curious because.
And it's also supposedly a cause of basal lung fibrosis. I have a couple of cases of cysts in it.
I wonder if some of that lung fibrosis is from aspiration, though, from sort of altered mechanics and vagus nerve issues and stuff.
Okay. Those are my cases.
All right. Thanks, David. All right. Howard or Travis?
Oh, I can go.
All right.
I'll start with a few quick ones here. And since I know you guys still have cases to show, this was one from a couple weekends ago. 32-year-old guy who had undergone an esophageal endoscopy earlier in the day. He had a known stricture, and they ran into issues, and so he was sent to the emergency department to evaluate. So they did this looking for pneumomediastinum or pneumothorax. You don't see anything here. They did the CT, and this was actually a CT esophagram. So we have pre and post oral contrast, and you'll see that he has an interesting finding of his esophagus. He may have aspirated here, but you can see that there's actually air in the wall of the esophagus, and it extends the whole length of his intrathoracic esophagus. So this is kind of the lumen centrally there, and then it's all wrapping around it. So I haven't seen one of these in a few years, but this is, there was no leakage of oral contrast on this. So this is an esophageal, what's been termed an intramural dissection. So as opposed to aorta, where you would never say, it's not a combination of intramural hematoma and dissection, but it's just a dissection of air in the submucosal layer of the esophagus. And you can see there's no full thickness tear. There's nothing else to suggest that he has Boerhaave syndrome. So there was, he was just observed and then sent home. Shout out to some of my colleagues from Mallinckrodt. One of my co-residents had written this paper up about esophageal injuries, and you'll see there are a few examples in here. Sometimes you can see this with intramural hematoma of the esophagus as well. So this is a little bit of contrast leakage. In this one we didn't see that in this case, but I think here's a good example, similar, of air just dissecting around the lumen. And so he was asymptomatic from this. It was just that they weren't sure if they had fully perforated his esophagus or not. So I can't remember when the last time I saw one of these was, but it's been a while.
I showed a case of a esophageal duplication cyst hemorrhaging, leading to a esophageal intramural hematoma. The whole thing was just, the whole submucosa was filled with blood. I showed that like, must have been 6-7 years ago. But yeah, I've not, it's uncommon.
Yeah, very nice case.
So let's do this one next. So this one is, I've been waiting for path on this case and finally got it. This is a patient who 20 years ago, he's 67 now, and this is pre-lung transplant, his admission, he just had a lung transplant, but 20 years ago, he was diagnosed with sarcoidosis based on a mediastinal biopsy from a bronchoscopy. And just showing this case, you know, there's actually a little bit of a twist with the pathology. But I think just general approach to this when you're looking at fibrosis, obviously using either Fleischner or ATS criteria, you would say this is inconsistent with a UIP pattern or suggestive of an alternative diagnosis based on the upper lobe distribution, and there's some other findings too, even though there is honeycombing. So I think this is the best example of honeycombing I've seen in a patient, or what could be described as honeycombing in a patient with what was attributed to sarcoid. There's still some traction. I think some of the stuff in the lower lobes is kind of interesting because you have like these little cysts. They look like cysts along the bronchi. Some of it may just be that you have varicoid, traction in some of these areas. But some of this other stuff looks like it's discrete little cysts next to the airways. So based on his history, we thought this was all consistent with sarcoidosis and fibrosis related to that. When they did the explant, it's kind of interesting because they found a bunch of non-necrotizing granulomas in both lymph nodes and the lung. But you'll see there's quite a discussion from our lung pathologist. So there were, not only were there discrete like sarcoid type granulomas, there were a lot of poorly formed non-necrotizing granulomas as well. So they were wondering if there was a combination of HP and sarcoid in this. I don't know. You can see down here the discussion. I mean, obviously at this point, I don't think it really matters that much given that he's had a lung transplant, but it's just kind of a curious case. So, and yeah, he's a contractor, so he's been exposed to dust, but the hypersensitivity workup was otherwise negative at the time. But I think it's a good, non-UIP look though with honeycombing, people that aren't as experienced.
And Travis, I think it makes sense because it's sort of both along that delayed type hypersensitivity reaction where you get glomerulus inflammation. And, when you before you pulled up the path report, I was thinking it kind of looks a lot like HP, but I've never seen that much cystic stuff with HP in the upper lobes.
Yeah.
Travis, can you give us a coronal?
Sure.
This.
Yeah, so you can see it's.
Yeah.
Yeah, and it's very interesting now, but.
Yeah, very strange pattern.
All right, let me show one more and then save the rest maybe for next week. This one is not much of a diagnostic dilemma, but it is a good example of this. This is a patient who's neutropenic, and they have several small nodular foci of consolidation, and then they have this bigger area that looks more like what we've described as a bird's nest on here. And when you look at the arterial, if you look at the arteries, I think you can see that a segmental artery just is abruptly occluded going into this. And so this is, looks like good for an angioinvasive fungal infection, specifically for mucor. And so this one, they actually were able to isolate on bronch. It was growing Cunningham-ella, which is a mucorales species. And so, I think now the way these are classified, I'll show this really quick. It's important to remember that mucorales isn't really, one specific fungus, but it's actually an order, as you can see. And then all of these different families are mucor species. And so Cunningham-ella is one of those. So all of these can cause an angioinvasive mucor type appearance as this one does. So the only question I have, usually I think about mucor, we see one discrete angioinvasive lesion like this. What do you guys think about all of the other ones? How often do we see, multiple foci of mucor, or do you think there's something else going on as well?
No, I think we do occasionally see that. Yeah, sure.
Okay.
I mean, that would be, I'm back. I mean, you could have more than one fungus, but you know,
Yeah.
that I would go with Howard and say, yeah, these things
Okay.
are very do what they want. But can you show us the occluded vessel or the
Yeah,
interrupted?
I think that I've got a follow-up one too, and it looks more and more like a reversed halo with a nice well-defined rim of higher attenuation. I think that on the original study though, that if you scroll up, I think right here, that vessel just disappears right there.
Mhm.
I think there's an arterial branch that goes right into that, and I think the same thing is visible. Now it's harder to see here because I think it's right back in here. So it's portion, maybe it's a subsegmental branch within the apico-posterior segment, but I think there is one that just disappears right in there.
I think one thing that helps with these fungal lesions, these invasive fungi, as opposed to say bacterial infection, is that air bronchograms are not very common in these fungal lesions. I think it's because of a lot of tissue swelling and stuff like that, and you know the bronchi are being compressed or they're being filled. Because compared to bacterial infections, air bronchograms are pretty rare with the Aspergillus and with Mucor.
When I think, like we've talked, these look more like hemorrhagic infarctions, like you would see with a pulmonary embolism, rather than like you're saying, a bacterial pneumonia. And there was the one paper in radiology talked about how uncommon air bronchograms are in pulmonary infarcts from PE. So I think it's probably part of the same. Yeah, I agree.
I never read that paper, so yeah, okay.
I can pull it up, but I think they found, they looked at a bunch of pneumonias versus infarcts and found that infarcts were air bronchograms were uncommon. I'll find it while Jeff and Howard are presenting. So that's it for me, Jeff, for now.
Howard, you ready?
Okay. Over the last few weeks, I've shown you guys 3 cases of vaping-associated lung injury. This is the 4th one that I have, so we've had a couple of these in the last few months. So let me show you the imaging pattern of this one. This is the 22nd of June. This is the 27th, when his radiograph shows more opacities in his lower lungs. And on the same day, this is the CT, so this is what it looks like. Certainly not different from the other cases that other folks have shown and that are increasingly shown on Twitter and so on. So multifocal, multilobar, confluent geographic, ground glass attenuating opacities. So nothing particular about this, but attributed to vaping. And this patient too on BAL has some lipid in his macrophages. Oil red O stain is positive. And this person did okay, stopped vaping, left the hospital, but the findings otherwise very consistent with what one may see with vaping lung injury. We obviously don't know exactly what the pathology is in there, but otherwise very consistent in the appropriate context, of course, with that. All right, let me show you these 2 interesting cases. Let me start with this one. So here is a person with nodular parenchymal disease. More of the nodules are present in the left lung, and there are findings consistent with lymph node enlargement, particularly hilar, symmetric, and certainly one would look at this and say the findings are consistent with sarcoidosis. So that's an image from June. The one that I interpreted was this one. And an interesting finding on this radiograph compared to the previous one is the presence of more opacity and widening in the right paratracheal mediastinum compared to the previous one. So let me bring up the one from June. The trachea is slightly deviated leftward, but that's a fairly striking finding right there. But this person had another image 7 days later. So the time between these two is 7 days. And in 7 days, this is substantially enlarged. So something is happening rather quickly, just in 7 days. So I'll show you the CT from the 8th. And indeed, there is one big enlarging lymph node, maybe more than one, but this corresponds very nicely with that. So there's rapid enlargement of this lymph node. I'll show you also that when you look at the lung, adjacent to it is ground glass opacity in the contiguous lung. So this is a very intense inflammatory process, and it's rapidly changing. So that's certainly not consistent with a malignancy or even progressive sarcoidosis for that matter, but things are happening much too quickly. So it turns out, and I only found this out a little bit later, that a transbronchial biopsy was performed on September the 1st. So that's important information, because this is very consistent with an infectious lymphadenitis as a direct consequence of a transbronchial lymph node biopsy of the R4 nodes. And I'll show you this. There's one article, and here's two. If you ever have to make that argument, you can indicate that people have thought about this before. And of course, this is a very uncommon occurrence, but it's a well-described occurrence. That is infectious lymphadenitis complicating biopsies. And here are two articles that go along with that. And one of the complications described always is infection. So that's interesting, but it just turns out almost by chance when I asked someone about that, they said, oh, we've had another patient with that. So let me show you the other patient, because this is also quite recent. So here we have extensive opacity, and indeed that's enlargement of paratracheal lymph nodes, and not just that, but also subcarinal. So that's very substantive, that's huge. And this patient too, and we didn't get that history initially, had a biopsy as well. But let me show you this one and show you the follow-up too, because, sorry, this one did not only involve the lymph node ultimately, but also the time here between 26th and the 2nd began to involve the pericardium, with pericardial fluid and pleural fluid. And you can see that things are happening rather quickly and extensively. And in this particular person, a streptococcus was cultured from blood. So this is a biopsy, another biopsy-associated infectious lymphadenitis. The biopsy was done May 22nd. And in this one, clearly involvement of both pericardial space and presumably the pleural space, but for sure the pericardial space. So two cases of undoubtedly, I think, post-biopsy infectious lymphadenitis. This one culture positive, the other one not. So I have three cases of this now. This is my second and third case. And I'm sure I've probably missed other cases or not known about other cases, because this case was unknown to me.
Howard, is the thought that they seed the lymph node with the biopsy needle from elsewhere, or is it a airway contaminant that seeds the lymph node when they do the biopsy?
Definitely seeding from the biopsy, but
I mean, like if let's say they biopsy the lung and then they go do the lymph node, is it thought that the organism is in the biopsy needle, or is it just like a skin contamination, except it's an airway contamination?
Or yeah, just normal flora in
Going
the
through
airway.
Trypanosomes is a pretty ugly bug.
right. In the patients, there was no transbronchial biopsy performed in the lung via the bronchial tree in the lung, just EBUS-guided lymph node biopsy.
So the presumption was the biopsy went through the needle went through the working channel, and somehow when they punctured the lymph node, the bacteria got in there somehow, either directly or through the hole.
That's what I assume. Exactly right.
Yeah, because a few months ago I showed a duplication cyst that had been there for years and completely asymptomatic, and then they tried to aspirate it, and then the next thing you know, the guy comes in with an infection of the duplication cyst. So they're introducing something, you would guess, because the airway's not sterile.
Right. Yeah.
Neither is the mouth or the nose that you have to go through on the way to the airway.
Yeah.
Yeah.
Exactly. I'm trying to see the overall incidence of this. It's obviously not great, but it's definitely a thing. So here, infectious complications in 0.19%, mediastinitis, and so on.
So it looks like it's pretty rare because that was all infections. So they had 7.
Yeah. Infectious SAE were most prevalent, 0.07. Interesting, it says predominantly patients with cystic lesions and sarcoidosis. You know, you wonder whether some small degree of steroids, which both of these patients actually were treated with, had some role. So yeah, very uncommon, but it happens. The true incidence may be higher as accurate documentation is missing in most studies. Yep. So there you are, 2 cases undoubtedly of that complication that I have. All right, Jeff, those are mine.
All right, I'll show a few, and then if Travis wants to do another 1 or 2, let's see here. All right, let's start with this one. All right, so this is a middle-aged female patient who carries a diagnosis of Sjogren's syndrome, and this is a CT scan. That's not what I want. There. This is a CT scan from about over a decade ago, and you can see at that time there's some thin-walled perivascular cysts with a basal predominance. So we see this a lot in Sjogren's syndrome, and there's actually quite a few cysts already even back then, and some ground glass stuff that may or may not be related. But a good look for lymphoid interstitial pneumonia. Cysts can be one of the findings of it, and seem to see this most commonly with Sjogren's syndrome. There is some consolidative stuff here. I don't know if she just had a little infection or what that was, if that was some lymphoid aggregates or malt tissue or something. Anyway, that was her original scan. Then she showed up later, and let's put them side by side. This is about 2 years after the first scan. Where's the synchronizer? There we go. And you can see that the cysts are starting to increase in number and size a little bit, but not a huge change. Now I'm going to jump ahead, and this is now about 11 years after the original scan. And you can see there's more cysts, and they've gotten a lot bigger at this point and become more confluent. And I thought I had the one in here. At some point, she developed a spontaneous pneumothorax, which I have never seen with LIP. And then this is the most recent scan. And in this case, you can see they've even become confluent. And now she's got some fibrosis, some traction bronchiectasis in both lungs along the bronchovascular bundles. But I've seen progressive cystic disease, but I don't think I've ever seen them get this big. And then she developed this sort of, I don't want to call it honeycombing, but this sort of cystic stuff, especially in the right lower lobe. And I guess that's just all part of this process. But I don't know, Howard, you've done some stuff with this. What do you think? I mean, to me, it just looks like progressive LIP, and whether or not this is NSIP or just fibrosis related to the chronic inflammation. But it's just, I mean, pretty progressive cyst enlargement, confluence, a spontaneous pneumothorax.
With that reticulation, I'm wondering about amyloid.
Like out
too.
here?
Yeah.
It's a good possibility.
I like I was waiting for Howard to shout light chain deposition disease here.
Yeah, but that typically involves kidney, and she doesn't have kidney involvement. So, I mean, I guess it's a possibility that I think from a lung imaging standpoint, we can't tell the difference.
Yeah, I still think of protein deposition, but it is unusual how big this is. So it's just a progressive process.
Yeah.
And they're getting dramatically larger over a relatively long period of time.
Right. And I think I showed one case of this, but also developed a lymphoma with an enlarging nodule. I don't know what this soft tissue was on the original one, if that was just some lymphoid aggregates of cells or beginning of some inflammation that led to this. Because if you go to that same area, there's now traction bronchiectasis and sort of what's remaining of the lung. But kind of an interesting case. I've just never seen them get this big. But I think that you have a case like this.
Biopsy, right, Jeff? No lung biopsy ever?
No
biopsy?
No good reason to, because of Sjogren's syndrome, the presumptive diagnosis.
Yeah.
But I think another important thing is when you are presented with a case like this, where you have sort of advanced lung disease, it's very helpful to go back to the beginning. And I'll show another example where that's really helpful in sort of sorting things out, because this one I think would be straightforward for the majority of us. You know, look at it's pretty typical with the perivascular basal predominant thin-walled cysts.
So, Howard, how much do you think we should invoke amyloid or light chain disease in this case?
Well, I still think the basic pathogenesis is the deposition of protein, immunoglobulin-associated light chains, because that's what we know happens in Sjogren's syndrome. Whether there is more than just a granular protein, that is a fibrillar protein with amyloid, one can't tell what's in the lung. Sometimes I suppose one could have both the granular protein, the non-amyloid protein, and amyloid protein simultaneously, but I don't know that. But I think the pathogenesis of those cysts is just continued deposition of protein and then just progressive over time elastolysis and dissolution of lung parenchyma from the matrix metalloproteinases released by macrophages.
Okay, here's another case. I won't tell you the history right away. So this is another example where I think it's very helpful to go back in time to get a sense of what's going on. So patient has a smoking history, and then at presentation, which was about a decade ago, has this pattern of fibrosis where you see sort of this somewhat peripheral reticulation, and some of it's a little bit more central, but it's predominantly anteriorly located in the upper lobes. And it's patchy, not horrible disease. But then as you go down, you see it more posteriorly located in the lower lobes. And there's a little bit of offset from the pleura. You can see some dilated airways. But overall, and it sort of spares the very bottom. So, I mean, and this has been described as the four-corner sign. Jonathan Chung and colleagues at the University of Chicago described this in an AJR paper a few years ago and showed it associated with connective tissue disease. And I think a lot of this is, in areas that we see aspiration, but also, NSIP, especially in the lower lobes, can have this sort of offset when it's really mild. But this patient ends up having rheumatoid arthritis, where we typically see a UIP pattern more often, or at least what we call a UIP pattern. But I want to show you the scan. It has a couple of features, I think, that make me always question it. And I know Travis and I have talked about it. So we're jumped ahead 9 or so years. And it clearly looks like there's holes. I mean, there are holes in the lung. Not all of them are subpleural, but some of this you could argue looks like honeycombing. I'm saying looks like it. I don't know if it is or whatever honeycombing is. But there's this interesting sort of dropout at the very bottom of the lungs, which is a little odd for a UIP pattern. But it's pretty peripheral, subpleural, so I'll stick with that. And then the upper zones, you've got a lot of emphysema admixed in here. So, but one thing that's conspicuously missing is there's really not a lot of traction bronchiectasis, even if you go out in the periphery. I mean, here's an airway right there. It may be a little big, but it's almost disproportionately the opposite. Like with some of NSIP, we see a lot of traction bronchiectasis, but no honeycombing. But in this case, it's almost exuberant honeycombing with little airway involvement. And if you just showed me this case and told me no history, I'd probably end up just calling it IPF with some pulmonary hypertension, saying, yeah, it's a little funny there. But yeah, it's still basal predominant, it's still subpleural predominant, and there's really nothing inconsistent. But looking at where he came from at this time, it's the wrong one. Sorry, it was this one. There, it does. You would not want to. You would not really invoke UIP at that time.
Right.
So, and it has been, we know that with, at least with NSIP pattern, but with CTD in general, I think over time they can evolve into what looks like a UIP pattern. So I don't know what you guys think. I mean, I would say it has features of a UIP pattern now. Clearly, it's advanced lung disease, and we know it's more common with smoking and rheumatoid. I don't know if it makes a difference at this point. I mean, they treat the rheumatoid arthritis, but
I've seen a lot of rheumatoid with an NSIP pattern. I've seen it with a UIP pattern, and I've seen it with features of both and
Right.
evolution of both. So I think it's all a spectrum. And RA of the collagen vascular disease is the one that's more likely to have a UIP element, but it doesn't mean it is always that way.
right.
Yeah, but so the interesting thing about that is that all the people that have imaging that looks like NSIP, the one study that actually had explants or open lung biopsies on those patients, all of them except for one had UIP pathologically. So even the ones that radiologically people said, oh, that looks like NSIP, in the rheumatoid population, they were UIP. And the question is, technically that's fine. You would call that findings of an alternate diagnosis because the patient has rheumatoid,
Right.
and we know it's UIP, but you would look at that and call UIP, but it's not going to be a classic for an IPF pattern, which is what we're really saying when we say typical for UIP, because it's not. It's a different type of injury leading to a similar fibrosis. But anyways, I'll stop there because I can rant for 5 hours on this. Okay, thanks.
Okay. So here's another case now. So I showed you guys last time I was on a couple of weeks ago a case of recurrent HP, farmer's lung, and a farmhand who got an acute active form of it with the classic ground glass and air trapping, went away and then got better, completely cleared his CT, but then went back and worked on a farm 5 years later and recurred. Now here's another case, which we don't typically see the evolution of HP very often. So this was the patient's original scan. I apologize, the window level defaults are all messed up on here, but at the time, and it's an outside CT, and so it's not thin section, but you can see that there's some mosaic attenuation, and maybe you can hallucinate there's some ground glass central lobular nodules in here, especially seeing better at the base. So, it looks like Seth's case without the emphysema. And this is another case of farmer's lung, but it's a pretty good look. And patient had a clinical history that fit with it. There, you can kind of see if I can bring them out a little bit, but you can see these central lobular glass nodules. So a nice look for so-called active, or what we used to call acute subacute HP, where there's a close proximity to the exposure. Most of the fibrotic HP we have, they don't have those acute histories. They often, the exposure has been long-term, so it's probably sort of a low-grade smoldering process. Well, this patient was treated, but it wasn't clear, but it doesn't sound like there was true antigen avoidance. And now this is what the scan looks like, which would be a great look for HP. So it's peripheral and peribronchial fibrosis, some traction bronchiectasis, maybe a few little honeycomb cysts, and sort of has that diffuse distribution, really basal predominant, and there's too much peribronchial disease. And then you still see the air trapping. I got some expiratory images that show a little bit of the air trapping. Although in my experience, the air trapping gets less conspicuous as the fibrosis gets worse. But I've not seen too many cases progress from sort of the non-fibrotic, the more cellular ground glass nodules to a fibrotic lung disease, because I think most patients just they get treated and they avoid it. Or more often we diagnose it as just a chronic lung disease and there's really no history of acute flares.
And in this patient, the time period between the two CTs is
about
8 years.
8 years.
8 years. Gosh, it's unlucky.
Yeah, yeah, just to see it progress to
unable to avoid the antigen.
Yeah.
So he was a farm worker guy, right? So
it was exposure to agriculture, which is what most of our HP is here. So,
got it.
Just real quickly, while I have you guys here, I was going to show this case because I don't know what it is yet. But this patient has this funny stuff in the mediastinum, and it looks like discrete little blobs that may be connected. There's some calcium in them. And then there's the second one down here. Now, if I just saw this, I'd question thymoma or something. It's I think a younger side patient, but the fact it's got these multiple ones. They biopsied this one, and it just showed normal thymus tissue. Have you ever seen anything like this? I wonder if this was like some weird cystic degeneration of the thymus. I mean, it almost looks like a treated lymphoma, but there's no history of lymphoma, no B symptoms.
I showed weird case 6 months ago or so that was presumably like nodular thymic hyperplasia after immunotherapy that was very ill-defined and multiple masses like this. I don't know, but that was in a patient treated. I don't know what this is.
I think they're going to resect it, maybe, but I mean, I'll get some. I was just curious if you've ever seen anything else.
I have, and similar thing where I called it a thymoma, and they took it out, and it was all degenerative. It was like thymic cysts, but the weird thing was I had time points, and it was growing.
Yeah, I only have a week.
And I said it's clearly thymoma. And they took it out, and they said there was nothing there except thymus. So I ended with cystic stuff. So I don't know.
Okay.
Yeah.
All right. Well, I'll follow up with that case if I ever get any feedback. Follow up on it, but I think it's going to go to surgery at some point. All right. Well, thanks, guys.
Okay, so gentlemen, on the topic of the vaping paper, I've really not made any contribution.